No mai, haere mai. Hello and welcome to your Intro Education session on the Upgrade 2024. There are some general changes which will affect all users. The first is that Momentum has been bought by Civica, so there will be a name change in the software. We are going to refer to the assessment software going forward as the Intro Assessment Software, or IAS. When you log in after the upgrade, you will see their new branding inside the software. The next major change is very exciting. We are moving to a single page application for our assessments. This is also known as SPA. You can watch a further video of the SPA and information on how to navigate this on our website. There is also a new mobile application which is replacing check-in, check-out. The mobile application and SPA will be available for home care, contact, palliative care, long-term care facilities and the acute care assessments. Currently, ACC contacts will not be moving to SPA or the mobile application. You can watch a video for more information on the mobile application and how to install it on our website, or you can refer to the What's New document for a guide on how to install this application. Let's look at what changes are in the acute care assessment. In the new single-page application, when you open your acute care assessment, you will first need to select whether you are conducting an admission, review, or discharge assessment. This will determine which items open for your assessment. The acute care assessment now has the following outputs available for you to use to support your decision making. These include the functional outcome scales, the geriatric screeners or syndromes, the risk for adverse outcomes, and the clinical action points or CAPs. When you code your AC assessment, algorithms work in the software to produce these outputs. The outputs help to identify a person's potential problems or risks which may need to be looked at in their care plan. The problems identified at the admission assessment and discharge assessment may vary, reflecting what actions a person needs during their acute stay and what they may need when being discharged. You can refer to Workbook Unit 5 for further information on the different outcomes and outputs. Outcome scales are now available in the acute care assessment. They have a purpose of being an indicator of an individual's severity of a problem at the time of assessment and can be used to assess progress over time. Full details on all of the outcome scores will be made available in your Workbook Unit 5, which is found on the IL&D site. Let's take a look at some of these. We have the Activities of Daily Living Hierarchy Scale. A scale range of 0 to 6. The higher the score reflects a greater dependency with ADL function. This scale looks at ADL loss over time. Early loss ADLs would include things such as dressing and personal hygiene. Mid-loss ADLs include transfers, locomotion and toilet use. And late loss includes eating and bed mobility. The ADL hierarchy scale is particularly useful for grading how disabilities amongst a group of older adults progress over time. ADL short form scale has a scale range of 0 to 16. It uses the same 4 items as the Activities of Daily Living hierarchy, but is more sensitive to change over time and has a focus on self-sufficiency and performance. The body mass index is used only in the admission and review assessments. It is a measure of height and weight and commonly used to classify levels of underweight, overweight and obesity in adults. BMI does not distinguish between muscle weight and bone density and fat and is only an indication whether a person is in the healthy normative range. There are other factors which can affect a person's BMI. Inter-eye MDS assessments use the BMI to identify people with clinical risks related to being underweight or overweight, and they allow for the ability to compare a person's BMI over time. The Cognitive Performance Scale is a scale range of 0 to 6 and made up of 4 factors including decision making, short-term memory, making self-understood, and eating. It is an important indicator of the risk of decline and helpful in planning day-to-day care. The higher the score on the CPS scale indicates worsening cognitive function. The communication scale has a range of 0 to 8. The higher the score indicates more impaired communication. The simple method assesses communication, looking at how the person expresses themselves and comprehends. If a person scores 6 or more on the communication scale, their ability to process language, that may be verbal, written, or signed, is considered severely impaired. The pain scale, which ranges between 0 and 4, is made up of 2 items from the assessment: pain frequency and pain intensity. It is validated against the visual analog scale. Again, the higher the score, the higher the level of the person's pain. The pressure ulcer rating scale, which is assessed only on the admission assessment, has a scale range of 0 to 8. The higher the score, the greater risk of developing a pressure injury. This goes alongside the clinical action point, which we will explore further soon. This scale has been validated against the Braden scale. And finally, the short depression scale. This has a scale range of 0 to 6, with higher scores indicating a higher likelihood of depressive elements being present. It is made up of 3 self-reported items and features only in the admission and review assessments. There are 4 screeners now available in the acute care assessments. Screeners are used to assist in the identification of a problem that is not easily detected with a single observation. A positive indicator on any of these screeners may identify the need for a further assessment or referral. It's important to note not all 4 screeners are present in every assessment type. The delirium screener is made of 2 coded items: the disordered thinking of awareness or acute changes in mental status. A score of 1 indicates the person is highly likely to have a delirium. The dementia screener helps to identify dementia at the time of assessment by utilizing the cognitive performance scale. The undernutrition screener uses 2 coded items, including the height and weight, which combine to make the BMI, and weight loss. A score of 1 will be indicated when the person has a BMI of less than 22 and has had recent weight loss. This is detected in more than 25% of the older general medical patients. The depression screener looks at anhedonia, or the inability to feel pleasure in normally pleasurable activities. When this is combined together with impaired activities of daily living and a history of ED presentations, it is strongly indicated the person will have repeat ED admissions within the next 28 days of discharge. For more information on these screeners, please refer to your Workbook Unit 5 in the ILMD site. The identifiers for risk adverse outcomes are now also available in the acute care assessment. These help identify the likelihood that an adverse event will occur in the future. There are 4 areas that we look at. The first is ADL decline. This looks at a person's risk of ADL decline and is scored by combining the activity of daily living short form scale and cognitive performance scale. A person's cognitive ability is a significant factor in rehabilitating after an acute hospital stay. The next area is falls. These can be increased due to acute illness and delirium. The falls has two risk levels, medium risk and high risk. The items used to inform this are vision, balance, cognitive performance scale on admission, and falls in the last 90 days. The pressure ulcer risk of adverse outcome looks at and screens for the person's likelihood of having a pressure ulcer. The higher the score, the greater the risk of developing a pressure ulcer. Readmission is the final one, and this looks at unplanned readmissions within the 30 days after discharge. This is determined by when they were last in hospital. For further information on the risk adverse outcomes, please refer to Workbook Unit 5 on the IL&D site. Clinical action points are now available in the acute care assessment. These will show on the assessment summary for your admission and review assessments. They are designed specifically to identify patients who are likely to benefit from a care intervention. They trigger for two main reasons. The first is for prevention. This is where the person is at risk of an adverse event, and that event could be prevented. The second is for treatment. This is where the person has a problem which is amenable to effective treatment. Further information on the clinical action points will be made available in Workbook Unit 5, which is found on the IL&D site. There are 10 clinical action points which will be covered. The first is ADL prevention. The goal of care is to look at preventing the decline in ADL function for vulnerable individuals. ADL treatment has a goal of care to improve function with newly acquired limitations. The behaviour cap has a goal to identify and provide interventions. The delirium treatment cap has a goal of early identification to reduce the severity and duration of delirium. The depression and anxiety cap looks at helping to identify the cause and severity and then provide treatment. The falls cap has a goal of care to identify the risk of falls. The pressure ulcer prevention cap looks to identify those at risk and initiate interventions. The pressure ulcer treatment cap has a goal of care to identify the cause of injury and to provide treatment. The readmission cap has a goal of care to prevent readmission following an acute event. And finally, the undernutrition cap. This has a goal of care of looking where undernutrition is present to evaluate the reasons for and instigate appropriate treatment. The assessment summary section is now available when completing your acute care assessments. This will be an optional field, but is an opportunity for you to identify what interventions you need to put in place to make a difference. Here is an example of what it looks like. You will see each clinical action point area laid out. If you click on Details, you will be able to find out why the clinical action point has triggered. On the side, you can view your outcomes and screeners. There is a limited word count in these boxes, so be mindful to keep it brief. If you are care planning, you'll want to tick Addressed in Care Plan. For further information and examples of how to complete the assessment summary, please refer to Workbook Unit 5 on the IL&D site. We are here to support you. If you need any help, please refer to the Interae website where information around the upgrade is stored. You can use the QR code to scan to take you to that website now. You will also find information in your workbook units which are saved on the IL&D site. These will be updated and released at the time of the upgrade. Feel free to watch the other recordings of the Skill Booster sessions on the ILND site as well. Ngā mihi he nui. Thank you for listening to our presentation. If you need any further assistance or help, please don't hesitate to get in touch.